So all of you may have heard the term meta-analysis, systematic reviews. In fact, I teach an entire course on systematic reviews, a whole semester long course, but I can only give you a very quick 30-minute teaser on what this is all about. So let me give you a couple of case studies to kind of drive home what systematic reviews are and why we actually need them, okay? So let's talk a little bit about this famous case study on human albumin, okay? So when people lose blood, right, when they are bleeding, we often need blood transfusion, but until then, people also use human albumin, right? Albumin is what you find in egg yolk. It's a protein, right? So people were using massive amounts of human albumin when people were in shock because of blood loss or burns, and it was a big mega $1 million market, right? Human albumin was expensive. It was worth millions of dollars, but somebody, a group of Cochrane reviewers, asked the question, does this thing really work, right? We're spending a lot of money on albumin, but is there any direct evidence that it benefits people, right? Could we just as well give normal saline or a crystalloid solution and still get the same effect? So they had very few trials at that point, and they were mostly smallish trials, but they did a very careful search. Multiple databases were searched, and they found a total of 30 randomized control trials, 30, okay? But each trial was fairly small. You saw 30 trials. Between them, only had about 1,400 randomized patients, right? But when they meta-analyzed those 30 trials, that is, they did a weighted average of the risk ratio of the 30 trials, they came up with the pooled risk ratio. Pooled risk ratio is the weighted average. A pooled risk ratio of 1.68, which was statistically significant, which suggested that albumin was actually harmful, right? Forget benefit, it was actually harmful, and it actually killed people compared to not giving albumin or giving another type of a fluid. And so this Cochrane review was published in BMJ, got a huge amount of press, and resulted in a major policy shift in critically ill patients that human albumin is actually potentially harmful, right? So this meta-analysis was very influential in changing policies around giving human albumin solution to critically ill patients. The second interesting case study is Vioxx. All of you have heard of Vioxx. It was the blockbuster drug for the company Merck. And Vioxx was used for rheumatoid arthritis and other patients with musculoskeletal disorders. And it was a huge money spinner for Merck, okay? But in 2004, Merck officially withdrew the drug from the market, okay? Vioxx was withdrawn because a trial showed that rofecoxib, which is also the same, the brand name is Vioxx, increased cardiovascular risk in patients that are taking the drug, right? But then the question is, if Merck withdrew the drug in 2004, did they already know this drug was harmful for cardiovascular risk before that or not? How do you find that out? So Peter Huney and others published an analysis in Lancet where they did something called a cumulative meta-analysis. You basically take all the studies or trials on a drug and you chronologically order them, okay? You take the first trial, okay? Then the second trial comes along. You do a small meta-analysis of the two, right? So here is the first trial on Vioxx. That was in 1997, okay? That was the risk ratio, relative risk, with the 95% confidence interval for one trial. And then in 1998, the second trial comes along, right? Then you take the first two trials and you do a weighted average, okay? Then the third trial comes along, you add it, you do a meta-analysis of 3 trials, then the fourth and the fifth and the sixth and the seventh and the eighth. And then a certain point comes when you start realizing that you already know that this drug doesn't work, because say by the year 2000, there was enough indication that the drug was dangerous and statistically significantly so, because a 95% confidence interval does not touch the null value of 1. Okay. Even by end of 2001, there was pretty rock solid evidence from multiple studies that Vioxx was dangerous with a risk ratio of 2.2 against Vioxx, right? 2.2 in favor of the control arm. So the question is, if you already have clear evidence from accumulating evidence that something works or doesn't work, why did Merck wait until 2004 to withdraw the drug, right? So the authors said Vioxx should have been withdrawn several years earlier. The reason why manufacturer and licensing authorities like FDA did not continuously monitor and summarize the accumulating evidence needs to be clarified. In fact, this was a disaster for the US FDA, this Vioxx scandal, and it led to a dramatic restructuring of the US FDA. But this is a nice example of a technique called cumulative meta-analysis. So now, for example, we know there are 3 randomized trials on hydroxychloroquine. The 4th one will come along. You can do a meta-analysis with 4, then the 5th and the 6th. If you do a cumulative meta-analysis on hydroxychloroquine for COVID, which I promise you people are already doing, you will soon come to a point when it will become crystal clear whether hydroxychloroquine is beneficial or useless or even dangerous, right? So something like this is a very valuable technique called cumulative meta-analysis. And then I already showed you the male circumcision meta-analysis. There were a whole bunch of observational studies. Nobody knew whether this was confounding or not, and the field could never agree on whether circumcision was beneficial. And then 3 randomized control trials came out, and you meta-analyze them. They all line up beautifully, right? This is a meta-analysis which I've never virtually seen. There is virtually no variability. Every single trial showed a similar protective effect. And you combine all of them, you get a 60% protection due to male circumcision for reducing HIV, right? Very, very clear-cut, consistent, homogeneous results, no heterogeneity across studies. You get a slam dunk result that male circumcision is a useful intervention. Now let's look at COVID-19, right? I've already found a couple of systematic reviews and meta-analysis online. I bet you dozens of them will be coming out in the coming weeks, okay? Here is one by 2 authors from India, only a preprint, not peer-reviewed, both from Bangalore. They found 11 studies in all, 3 randomized control trials and 8 observational studies, okay? After this course, all of you know exactly what that means. 3 RCTs, 8 observational studies, and the overall conclusion of this meta-analysis was our meta-analysis does not suggest improvement in clinical progression, mortality, or viral clearance among patients with COVID-19 who are treated with hydroxychloroquine. There was a significantly higher incidence of adverse events with chloroquine use, right? Those are the conclusions from this particular meta-analysis. And if you only look at the 3 randomized trials, all are small trials, you can see that, okay? Very small trials, all are from China. But if you did, you see this is the risk ratio or odds ratio from each of the 3 trials, and you did a weighted average, you get this diamond, okay? The tip of the diamonds are the 95% confidence interval, and the middle part bulge in a diamond is the actual estimate of odds ratio. And you can see here the odds ratio estimate is practically 1, right? 1.1, which means there is really no indication that in these 3 trials that hydroxychloroquine is helpful, right? It's the null result that you're seeing in this particular study. But the issue is there are really small trials at this point, and there is not enough evidence to conclude whether chloroquine works or not. And all of them happen to be from China. We obviously need to look at the quality of all the 3 randomized control trials at this point. But that's the highlight conclusion from this meta-analysis. But the problem is this meta-analysis is already outdated, right? Even since this meta-analysis, there have been new studies coming out on hydroxychloroquine. So how do you deal with this problem? I like this approach, a living systematic review, right? A living systematic review means as and when new hydroxychloroquine studies come out, the authors will update their analysis. So this was published in a prestigious journal called Annals of Internal Medicine. So if I were using this, I would go with this over the preprint that I just showed you. They've already found 4 randomized control trials, 10 cohort studies, and 9 case series. I hate these 9 case series. I would have thrown them out right away. Okay, I don't believe case series or epidemiological studies. I don't give them any credence. I don't discuss them. I don't lecture on them. I would just throw them out. Okay, to me, this is where the action lies. 4 RCTs and 10 cohort studies. Of these, I would any day value RCTs over cohort studies. For all the reasons that you've learned in this course, I am super nervous of observational studies on drugs, because who gets chloroquine, why they get chloroquine, how they are different from others who did not get chloroquine is a massive problem in observational studies. So as far as drugs go, I want to see randomized control trials. I want to see good quality randomized control trials. I want to see adequately powered randomized control trials, and then I bury the problem, right? So from this living systematic review, the big conclusion is evidence on the benefits and harms of using chloroquine to treat COVID-19 is very weak and conflicting. Basically, they're saying at this point, we don't know, okay? We just don't know. Limitation, very few control studies, and control for confounding was inadequate in observational studies. You folks can absolutely understand what this means now, right? After the 2-week course, you should know exactly what every word in this abstract means, because that's what you've been learning, right? They're basically saying we don't have enough RCTs, and the observational studies did not do a good job of controlling for confounding. Okay, this is where we are with the HCQ story. So keep an eye on this. I've given you the website link at the bottom. I bet you every couple of weeks they will be updating it, because that's how fast evidence is accumulating. All right, so those are all case studies, but there are hundreds of topics in medicine or public health where we're constantly asking, does this work or not work, right? Is this a good test for TB? Is this a good treatment for migraine, right? And systematic reviews are often the best source of evidence because they combine a large number of primary studies and come up with simple, relatively straightforward conclusions that we can take into our clinical practice, right? And this is why we need these sorts of systematic reviews, because we are now overwhelmed with literature, right? Thousands and thousands of papers are coming out every single day. And this was done a while ago, so it's already outdated. 75 trials come out every day, not just on COVID, on everything. I bet you now the number is more than 100, right? And then thousands of observational studies come out, right? COVID itself has produced thousands of studies and preprints. How do we keep up, right? We need guys like these who can actually synthesize this for us so that we don't have to go and read every damn individual study, right? We don't have time, we're too busy. If they do a good job of critically appraising and summarizing the evidence, then we owe them a lot, because they're doing what we cannot do, we may not have time to do, okay? So we rely on people who do systematic reviews, if they do a good job, to tell us what is the big picture evidence on a given study. Because single studies, we can always cherry pick what we like, what we hate, what we can easily find, but that may not reflect the actual totality of evidence. The only way to get at the totality of evidence is a high quality systematic review. And another reason to do systematic review is, if you're doing new research, don't forget the old literature on a topic, right? Maybe the question is already answered. Why would you do another chloroquine study now when there's already 150 registered? What will you possibly find that is new, right? Within a matter of a month or so, this chloroquine debate will be closed, because there'll be enough evidence, and this cumulative meta-analysis will tell us with great certainty whether this damn drug works or no. We can bury it and move on, right? So launching a new chloroquine study 3 months from now is just rubbish, and it's wasteful, and it should not be done, in my opinion, right? Because we always must look at what has been done so that we are not reinventing the wheel all the time, doing the 50th study on the same topic, right? And in fact, this was the biggest anxiety that Professor Sir Archie Cochrane had in the 1970s. In 1979, he wrote that it's a great criticism of the medical profession that we have not organized a critical summary by specialty or subspecialty adapted periodically all relevant randomized controlled trials. I think what he was basically saying was we're doing trial after trial. We're not stopping to synthesize what we know. So the whole field of evidence synthesis, also called knowledge synthesis, is a synthetic field which collapses literature on a specific topic and tries to settle the debate so that we don't have to do more and more studies on that particular topic. So Archie Cochrane's advice was taken seriously. And in the 1980s, Sir Ian Chalmers, who's like the founding father of Cochrane Collaboration, began something called the Oxford Database of Perinatal Trials, trying to accumulate all the randomized trials on just perinatal research, mother and babies. And then that then became finally the Cochrane Collaboration in the year 1993. If you look at the Cochrane Collaboration logo, you actually see a meta-analysis forest plot here, right? This was one of the first meta-analysis done, which shows that if a mom is going to have a preterm baby, and if you gave mom a steroid, that steroid helps the baby's lungs expand. It prevents acute respiratory distress in the fetus when the fetus is born prematurely. Okay, that's the actual real world figure of a meta-analysis forest plot from that Cochrane review on you giving steroids to moms who are going to have preterm babies. We still give that intervention, right? My baby was born prematurely and my wife got a steroid shot to help the baby's lungs expand. Okay, that's the Cochrane Library. You can visit the Cochrane Library website. You will see hundreds and hundreds and thousands of systematic reviews published on a variety of different topics. I'm sure there are Cochrane reviews ongoing right now on COVID. So now let's define. I've used the word systematic review. I've used the word pooled estimate. I've used the word meta-analysis. Let's try and tease these apart for you. Okay. So this is some kind of an onion diagram, right? The big circle is all review articles. Review articles, by definition, are not original studies. They are synthesizing all the literature on a given topic, right? I could write a review article on chloroquine for COVID, right? But the review articles don't necessarily have a clear methodology, right? I could cherry pick what I want. I could only cite the 5 positive studies on hydroxychloroquine. I could totally leave out the rest. I may not have a systematic approach to it. I may not have searched for all studies. But if you did this properly, you did a comprehensive search, you carefully looked for evidence, you quality appraised them, you critically read them, and you summarized them, then this yellow egg are called systematic reviews. So systematic reviews are a much smaller subset of all review articles. Now, within the yellow egg, you have a small white egg, which is meta-analysis, right? Within systematic reviews, you can mathematically pool all the risk ratios, rate ratios, hazard ratios, sensitivity, specificity. Any number can be pooled by doing what we call a weighted average. If you did that, then you would have done a meta-analysis, right? So, and within a meta-analysis, there is something called individual patient data meta-analysis, where you actually get the raw data sets from various clinical trialists, and then you combine them yourself, right? If you did that, you would have done an individual patient data meta-analysis. In practice, sometimes people do a meta-analysis, but they don't do a good systematic review, and that can be dangerous. You want to be doing a meta-analysis only within a well-done systematic review. Secondly, not every systematic review must end in a meta-analysis. You can do a systematic review, but you can choose not to do the mathematical pooling part. When do we do that? Well, if the results are too heterogeneous, that is, the results are too inconsistent across studies, then it is misleading to pool mathematically the numbers because you are pooling apples and oranges, right? You don't want to do that. So systematic reviews can be done, but meta-analysis is the last optional stage of a systematic review that you can either choose to do or choose not to do, okay? So I've given you definitions. A systematic review is a review in which there is a comprehensive search for all studies on a specific topic. Those identified are then appraised critically and synthesized according to a predetermined and explicit method, right? If I did a systematic review, I need to clearly tell you what databases I searched, how I found the studies, what was the inclusion criteria, exclusion criteria, what was the quality of the studies, so that you can replicate what I did. If you could replicate my work, then that's systematic, right? But if I didn't tell you how I ended up with those studies, if I ended up including all sorts of high quality and low quality studies, then that's potentially problematic, okay? You can look at my paper where I've given you a nice table on the difference between traditional reviews and systematic reviews, okay? A meta-analysis, by definition, is a statistical combination of at least two studies. You need at least two trials to generate the diamond, right? The diamond is the pooled estimate in a forest plot. If there's only one study, there is no meta-analysis, okay? So it's a statistical combination or pooling to produce a overall odds ratio or an overall pooled risk ratio. That's what a meta-analysis is all about. For example, we have done systematic reviews on a whole variety of domains, not just randomized trials, right? So for example, we've done a systematic review on tuberculosis prevalence among healthcare workers, okay? Where we looked at prevalence of TB rather than clinical trials. We've done systematic reviews on diagnostic studies. So here is a systematic review my student did on rapid tests for influenza. We've done systematic reviews on various TB diagnostic tests. We've done systematic reviews on treatment-related issues, right? Randomized controlled trials. And we've done systematic reviews on exposures, right? Is tobacco smoking associated with TB? Only observational studies and only focused on an etiological question, right? So you can do meta-analysis and systematic reviews on all types of studies, not just randomized controlled trials. And all systematic reviews pretty much have the same type of approach. You first define a focused review question using the PICO format. You do a very comprehensive search to identify all the literature. Then you assess the quality of all the studies you found. Then you summarize them using tables, forest plots, meta-analysis if acceptable, and then you interpret the findings, okay? And my team has published a detailed roadmap on how to exactly do this, right? So obviously this is not for you folks, but if anybody came to me and said, we want to do a systematic review on this topic, I give them this one-page handout and say, this is what the roadmap looks like, right? It's a long, painful process. It's a lot of work to do a good quality systematic review. If you ask me how many months can it take, well, I'll tell you that it depends heavily on the disease area. If there are lots of studies, then it can take months and months of work to do a good quality systematic review. So this roadmap that we published, we also have French version, Spanish version, and Chinese versions available on our website, okay? So a good systematic review is heck of a lot of work, but it can also get published in high quality journals. We publish them in Lancet, we publish them in Annals, and they often are very influential in making a decision on what to do with a particular intervention or test. Then just to kind of wrap up, meta-analysis can sometimes be misleading. You need to worry about that, right? When can a meta-analysis mislead? Ideally, you should not do a meta-analysis without a systematic review, right? Always do a systematic review. Meta-analysis may be done, may not be done, right? That's fine with us. But systematic review and the systematic nature of it is very important, right? If you include really poor quality studies or you completely ignore study quality, then that's a pretty difficult problem to overcome, right? Think of garbage in and garbage out, right? A meta-analysis inherently can't be better than the input studies that went into the meta-analysis, right? Just because you're doing a fancy meta-analysis doesn't mean the garbage studies that went in will not be misleading, right? So ideally, you should completely exclude poor quality studies, right? Or you should keep them separate in the analysis. But if you mixed high quality and low quality and then scrunch the overall pooled odds ratio, then you produce a number that cannot be easily interpreted. For example, I get all agitated when somebody does a meta-analysis combining observational studies and randomized trials in the same analysis. That to me is a no-no, okay? If you do a meta-analysis, then you separately meta-analyze the randomized trials. You can separately meta-analyze the cohort studies, but please don't mix them all up into one analysis because that's disastrous. Randomized trials are inherently superior because confounding is not an issue, while observational studies, you always worry about confounding, right? And then when you meta-analyze when the results are all over the place, let's say the odds ratios are highly variable, right? Some showing protection, some showing harm, and then you scrunch them together into a pooled estimate. You end up with this very weird overall pooled estimate that simply cannot be interpreted, right? When there's a lot of statistical heterogeneity across studies, do not pool them, right? Because that's misleading, right? Next, there's a whole series of reporting biases, we call them, right? Publication bias is a vexing problem. We know from lots of studies that generally positive trials get published, negative trials rarely get published. If only positive studies make it into PubMed and you only find them to include in a meta-analysis, then you automatically cherry picking the tip of the iceberg and putting them in your meta-analysis. What about all the hidden studies or the negative studies, right? There's something called time lag bias. A positive trial will get fast-tracked by Lancet to publish within a week. A negative trial might take months or years to come out, okay? There's also something called duplicate publication bias. Same trial published in Chinese and then in English. If you count them both into your meta-analysis, then that's a problem because you've given one study additional weightage. You counted them twice, right? Language bias. Most systematic reviewers, including us, generally include only English studies, right? My team sometimes, because we are in Montreal, we often also include French studies, right? But that's still only 2 languages. Do we include Chinese trials published in Chinese language? No. Do we include Russian trials? We don't, right? So we don't include Spanish trials, Italian trials, German trials. There's no end to this, right? So one big criticism is that if you only meta-analyzed English studies, are you really missing a lot of evidence, right? And then lastly, you already saw, even within a trial, people generally report positive outcomes. They bury the negative outcomes, right? And then again, you meta-analyze the positive outcomes. You end up with a positive conclusion. So you need to worry about all of these issues. And you also need to worry about conflicts of interest of people doing the meta-analysis, right? So there's conflict of interest on part of researchers doing the original trials, but there's also a conflict of interest on people doing the meta-analysis as well. Even that needs to be declared transparently in the paper. So let's take questions that you may have.